Good morning, everyone. We have the advantage of the fallback of the time on our side, so we're all wide awake this morning. This morning, we are holding the first of our series of speakers highlighting faculty from outside the Department of Surgery, but across the campus, who are engaged in high-quality funded research. This is spearheaded by the Vice Chair of Research, Dr. Kovacs. And we expect this will be an eye-opening and hopefully inspiring series for our faculty and our trainees to pursue high-quality research, and it might even lead to some mentorship and collaboration. This morning, I have the pleasure of introducing Dr. Daniel Matlock, Professor of Medicine in the Division of Geriatrics in the Department of Medicine here at the University of Colorado. Dan hails from Golden. He did his undergraduate education at the Colorado School of Mines in chemical engineering, attended medical school here at CU, obtained his Master of Public Health at the CU School of Public Health, and did his residency in geriatrics fellowship here, and then has been on faculty here. Dan is the Vice Chair for Health Services Research in the Department of Medicine. He's the Associate Director of Clinical Innovation at the Denver VA, and the Director of the Colorado Program for Patient-Centered Decisions at Accords, with whom many of us collaborate on our health services research. His research is aimed at fundamentally changing and improving how patients make decisions around invasive technologies. He's been funded under several, and it continues to be funded under several grants from the NHLBI, NIA, NCI, and PCORI. And he's studying shared decision-making among older adults making decisions around invasive technologies. He's also participated in the American College of Cardiology Shared Decision-Making Task Force and is an active participant in the International Patient Decision Aids Standards Writing Committee. So please join me in welcoming Dr. Matlock.
All right, thanks y'all for having me. Let me just make sure this, oops, there we go. All right, yeah, so I'm Dan Matlock. I'm really excited to give surgical grand rounds this morning, and thank you for having me. Some conflicts of interest. I have some grant funding to disclose. When I talk to cardiologists, I like to include this bottom thing, that I'm a member of the American College of Cardiology, even though I'm a geriatrician. And they let me join the ACC for like $100 a year. But I had to fill out this special thing saying I was either a geriatrician or a cardiovascular veterinarian. I'm not sure what that says about the ACC and how they see geriatrics, but I appreciate them allowing me in. So throughout the presentation, I'm going to talk about my research, but I have some fun psychology experiments trickled in around decision-making because they make some points and they make me think how I talk to patients, and I thought I'd share that with y'all. But think of this statement: there's a 30% chance of rain tomorrow. This is from an experiment that Gerd Gigerenzer, he's a psychologist who does medical decision-making and patient communication in Germany at the Max Planck Institute. He asked 750 people on the street in 5 different cities this question and had them check one of these boxes. It'll rain in 30% of the region, it'll rain for 30% of the time, or it will rain on 30% of the days like tomorrow. The correct answer is the last one. That's future probability. 30% of the days like tomorrow will rain. The most common answer was it will rain tomorrow for 30% of the time. And some of the quotes they put in their paper that people said are actually informative too. 3 out of 10 meteorologists believe it will rain. 30% means if you look up at the sky and see 100 clouds, then 30 of them are black. It's not about time. It indicates the amount of rain that will fall. And then I like this last one because I think it's right. If we had 100 lives, it would rain in 30 of these tomorrow. But it kind of highlights just the challenge of probabilistic thinking. I don't think shared decision-making is just about conveying statistics and information like this. I think it's a much deeper, richer, more human process. But I think the way we talk about numbers is part of it and part of how we communicate with patients. And we'll get into this a little bit. So what is the problem there? At least one piece, I like talking a little bit about numbers and how we present numbers, because that is a lot of the science that kind of pushed people towards decision-making, was just people's misunderstandings and people's misperceptions of what they were doing or getting into. Excuse me. So this is a more stark study. This is actually from the New England Journal. There's a little article that I'll show in a couple of the next slides. But in 1995, the United Kingdom Safety on Medicines issued this warning: oral contraception pills increase the risk of potentially life-threatening blood clots by 100%. And this is from the New England Journal. If you look at the rates of abortions in the years after that, they went way up, and the rates of unintended pregnancies went up as well. I'm not trying to make a social comment on abortion, but I think we can all agree that it's at least the proxy measure for unintended pregnancies. Because people heard that warning and stopped taking OCPs. And the actual increase was 1 in 7,000 to 2 in 7,000, which is indeed a relative risk 100% increase. But it's an absolute risk of 0.014% increase. And if you look at that misunderstanding in the years following, 13,000 additional abortions, 13,000 additional births, and then the irony is the risk of blood clots is about 10 times greater with abortions than it is with oral contraceptive pills. So this gets into one of the challenges, is this relative risk versus absolute risk. When we talk to patients, when I'm in clinic, and I think of a percentage, I'm really trying to be careful about what percentage I'm saying and what does it mean. And the problem is denominator neglect. When I present a relative risk to a patient, 100% increase, we as people, and there's studies that doctors do this too, we assume that percentage has a denominator of 100, not 1 in 7,000, but 100%. So we hear a 100% reduction, and some people will think that means everybody gets it, or they don't. Another problem that we saw in the literature that's much better now, but was the way the literature was framed around numbers. And often the benefits are framed as relative risk. Oh, if you take aspirin, there's a 20% decrease in the risk of stroke. But the harms are framed as absolute risk. Oh, but there was a 1% increase in the rate of intracranial bleed. And basically what you're doing is an apple and an orange. And if you go back to the 90s and look at abstracts in JAMA and the New England Journal, the benefits are relative risks and the harms are absolute risks, because it sells your intervention. It's a way to make it look like your intervention is better than it is. And so there's an incentive for writers to do that. That's gotten a lot better, especially at the major journals, but it still sneaks in. And I'll tell you, this relative risk, absolute risk tricks me sometimes when I'm driving in and listening to NPR and they're presenting some new thing and they throw out a percentage. I'm trying to figure out with the words they're using, what kind of percentage are they talking about? Are they talking about a relative or absolute? So this is just some of the science, and I'll sprinkle in a little bit more that informs shared decision-making and some of the interventions we develop. We spent 20 years developing tools and things for patients making major decisions. I love doing this. I'll tell you, I'm having an existential crisis because I'm starting to realize that robots are getting better than me at creating content. So I'm thinking these future grants, I'm trying to figure out how to engage artificial intelligence in this and figure out what is that human part of shared decision-making that's not going to get replaced. That's more a little personal issue that I'm needing some therapy with right now. But, and also I think is where the world's going. But anyway, a lot of what goes into our tools we make is some of this psychology science and some of these learnings from other fields about how do we help people best understand the information they're getting. I'm going to talk about a couple examples sprinkled throughout. These are the two we've done the most work with. We work with a lot of people and a lot of different decisions, but implantable defibrillators, this is what my NIHK award and my first PCORI grant, my first R01 were around. And then the LVAD work that I've done with Larry Allen and actually Joe Cleveland is one of the stars of our video. And that's the other work funded by a couple grants from PCORI that I'll talk about as well. But just riffing off the numbers a little bit, this is implantable defibrillators. This is from the New England Journal. This is 2005, which is kind of crazy to me, realize that I've been doing this for 20 years. There's not a new trial yet. There's a couple trials ongoing now with 20 years of improved heart failure therapy to see if defibrillators are still beneficial. But anyway, this is still the big trial that shows that defibrillators, implantable defibrillators, are good for patients with heart failure who've never had a cardiac arrest. They randomized just people with heart failure to placebo, amiodarone, or ICD therapy. At the time they started the trial in the late 90s, there was a question of, is amiodarone as good as a defibrillator? And it wasn't. It was as good as placebo. But you see, over 5 years of this trial, 36% of the patients without a defibrillator had a cardiac arrest or died, and 29% didn't. So there was a 7% absolute reduction in the rate of death. And as a primary care physician in geriatrics, for preventive medicine, This is better than most of the things that I do with blood pressure or cholesterol. This is a very big absolute risk reduction for any sort of prevention kind of medicine. But we surveyed every patient at Kaiser, Colorado with a defibrillator. At the time, it was about 400. There's a lot more now. But we asked them this question: if 100 people like you got a defibrillator, how many lives would be saved over the next 5 years? And I just told you the right answer was 7. But you see what people said. We chose these categories based on a prior question that some folks at Harvard had used with a smaller survey. And you see about 20% said 28, about 30%, 35% said 53. So people overestimate the benefits. And this isn't just picking on defibrillators. This is most things in medicine. People tend to overestimate the benefits. And part of it could be that we talk about things in relative risks. They hear an absolute risk and they put a different memory in their brains. Some of it could be things like optimism bias, one of the cognitive biases that people have. And then the flip is people often underestimate the risks. And these are pretty universal findings in a lot of things where people overestimate benefits and underestimate risks. Now the risks have some caveats. When risks start getting really small, then people start to overestimate them. Like the commercial where you just list off every risk, then people start to get confused and overestimate those risks. There's a great study where people, they were randomized to hear your risk of this terrible outcome is 1 in a million. And then the other half heard 2 in a million. And then they asked them 2 to 4 weeks later how great their risk was. And the people who heard 2 in a million actually rated their risk as lower than the people who heard 1 in a million. And the thought in the discussion was, well, when you hear 1 in a million, you don't think about the numbers, you just hear risk. When you hear 2 in a million, you think, oh, that's kind of a weird number. 2, okay, that's small. You put a different memory in your brain and you better calibrate your risk because you thought about it. And that gets into what we try to do with some of the decision aids and decision tools we do, which is present information in a way that's accurate and honest and helps people really understand what they're exploring and what they're getting into. So another experiment, this is back to a little more basic psychology. This is a fun experiment. It's a little old, 2000, but it's been recreated. It's one of the psychology findings that has been replicated when they had their whole replication crisis. But this is a fun experiment where this woman, I think she was doing her PhD. She took jars of jam and put them at a store. And on some days, she would put 24 different flavors out. And then on other days, she'd put 6 flavors out. And when she had 24 flavors out, it was this glorious display of color. 60% of people would stop and look, but only 3% would buy one. When there were 6 jams, fewer people stopped to look, but more people were able to make a choice. And people were more satisfied if their options were limited. And this is one of these psychology findings that is sort of replicated, that when we overwhelm people with choice, it actually makes it harder. And I think it's one of the things that makes our job hard. You don't just want to put a litany of options in front of somebody. You could actually be making things harder for them. What do they help narrow it down? What are the reasonable options? You'll help your patients make better decisions if you do, and make it a little easier for them. And this is just one of these cognitive biases. We don't like to spend effort in cognitive load if we don't have to. Same thing with physicians. Here's a paper from JAMA showing the same concept. David Rettelmeyer, who's a general internist somewhere in Canada, I think Toronto, actually published this paper with Dan Kahneman, one of the psychologists who won the Nobel Prize for psychology, or for economics, but he's a psychologist. But this was their experiment. They asked physicians, you've got a farmer, he's 67, he's got hip arthritis. You've tried several NSAIDs and stopped them because they didn't work. So you decide to refer him to orthopedics to consider a hip replacement. But before sending him, you check the formulary and then they got randomized to either the left or the right. Some said there's 1 NSAID left that the patient hasn't tried, ibuprofen, and the rest said there's 2 NSAIDs left, ibuprofen and piroxicam. What do you do? And you see the options: refer and start ibuprofen, or just refer and don't do anything. And then the other one is refer and start ibuprofen, refer and start piroxicam, or refer and don't start anything. So all of them are going to get referred. And you see on the right, when you give the doc more options, they're less likely to make a decision and just refer. So about half of them just referred on the left, but 3/4 went straight to referral once you gave them an extra option. This is that counterintuitive piece of how more options, because once now the people responding to the survey is like, oh, I don't want to make a decision. I'll just refer them and let them decide. Completely counterintuitive, but this is the way our brains are wired. And it's good to know that about ourselves. And this is, if you like this stuff, this is this behavioral economics or cognitive psychology. And these are a couple great books. Richard Thaler wrote Nudge. Actually, if you're going to read one, that one's a little easier. Richard Thaler won the Nobel Prize for economics just a couple years ago as well. But Thinking Fast and Slow is wonderful, written by Dan Kahneman. They're both great books. Thinking Fast and Slow is like a textbook written at a lay level. I listened to it in the car and it's thick. It took me a long time actually, because there's just a lot there, but it's fun. And it gets into a lot of these ways that our brains trick us into different decisions than what we think they should. It turns out we're just not that rational. Here's another one. This is a famous experiment. It's a little dated, and it's not the most PC term, but they called it, this was in the 80s, I think, 1981. They called it the Asian flu crisis. But they said, imagine you're a public health officer and there's an outbreak that's going to kill 600 people. And then you have to choose between program A and B. So half the people got the top, where you choose program A, which is going to save 200 people, and program B, where there is a 1/3 probability that 600 people will be saved and a 2/3 probability that no people will be saved. So these are identical from an expected utility perspective. 1/3 of 600 is the same as 200. The difference is the top one is the conservative option and the bottom one is the risky option. So this is testing risk-taking. But then what's fun, this is framing effects. This is partly what they won the Nobel Prize for, is this kind of stuff. On the bottom, they're framed as living or dying. 400 will die, a 1/3 probability nobody will die, and a 2/3 probability that 600 people will die. So the only difference is the top is framed as saving, the bottom is framed as dying. And when you frame it as saving, 3/4 take the risk averse option. When you frame it as dying or a loss, 3/4 take the risky option. And I think these were medical students. These weren't just lay public folks. These were medical students. So people you'd think would be educated and are educated. And this is what our brains do. These are the tricks we make. When we frame things as losses, we induce risk-taking behavior. When we frame things as gains, we induce conservative behavior. And this is what won them the Nobel Prize. If you buy insurance, if you go buy a new Blu-ray player or something from Best Buy, they offer you that little insurance for $15 to insure your $100 thing you just bought. You're basically saying, I think there's a 15% chance my thing's going to break. That's the highest profit margin thing for Best Buy, is because they're playing, you just gain something. So now you're a little conservative, and buying insurance is a conservative behavior because you just gain something. And so now we buy insurance. We're targets at that time for this profitable thing of buying a little extra insurance. And it gets into this. This is the psychology behind it. It's really interesting. So we think about this when we design these tools. We try to figure out, how do we frame things so we're not inducing a gain frame or a loss frame? And you can quickly see how this would influence how we talk to patients. Oh, if you don't do this procedure, you're going to die. Well, you just have induced a very risk-taking behavior. If that's true, you got to be honest with people. But the way we talk to them is going to have effects on them. So it's interesting. So back to some of the examples from the field, or the examples we've been doing. This is, again, the defibrillator. I've shown this graph. This is the Scud-Heft trial, the 7% absolute risk reduction. Well, this is the advertisement that shows up in my mailbox, summarizing that trial. This is from one of the companies. That's 23% reduction in the risk of all-cause mortality. And this is that using relative risk to try and sell things. And I think we need to be careful about that. If we use a relative risk, we should be at least thoughtful behind why we're using it. And I think there are times to use relative risks. I certainly will in clinic when I talk about the benefits of stopping smoking. If I can use an accurate, bigger risk number to induce a behavior that I want, that's a good thing. And that I know they want too, that's a good thing. But if I'm trying to help them make the right decision for them based on the risks and benefits, then I don't want to do that. And so it's interesting. So on to defibrillators. We talked a little bit about the benefits of defibrillators. There are a host of harms. They're pretty small. When I get to the LVAD, that's a different discussion. They have big harms, potential harms, but But with ICDs, they're pretty small. There's procedural risks. And then there are, actually, do you guys have any water or juice or something? Somebody mind grab me a little glass. I'm just feeling a little dry. Thanks, Rob. But additionally, with defibrillators, there's some data that people who have defibrillators have increased heart failure admissions. The thought there is you took someone who would have died of sudden death, kept them alive, which is great, but now they're alive with progressive heart failure. And this is where me as the geriatrician started getting interested in this. I take care of older adults, many of whom tell me they don't want me to do a lot of things to them. And so thank you so much. Oh, orange juice is great. There's a lot of people who say, if I could have sudden death, that's not the worst thing that could happen to me. And so I don't want a defibrillator, but that's a discussion with a patient, because there are other very reasonable patients who a defibrillator, implantable defibrillator is absolutely the right decision for them. So it's matching the right treatment, but with the patient. But some other harms, increased heart failure admissions, anxiety, depression. There's some data with defibrillators of people getting PTSD from getting shocked. Inappropriate shocks, which are much better now than they used to be. I actually have an updated version of this slide with much more recent references. Sorry about that. I guess I didn't shuffle that one in. Device malfunction, potential suffering at the end of life. With defibrillators, there was one study that half the hospices in the country had a patient who died with a defibrillator, but the hospice didn't realize that they should turn it off. And so as they were dying of some other cause like cancer, they started getting shocked by their defibrillator. And then quality of life data is pretty mixed on defibrillators, but I mention it as a potential anyway. But I think that, the risks versus benefits, that's part of shared decision-making. I think that's an important part. We should get good at how we communicate, but it's really hard. I think it's really hard for a lot of the things you do because you're in surgery, you're often very much tailoring your discussion to the particular surgical situation or the particular tumor or whatever you're going to operate on. And there's a lot of nuance there. Whereas when you're doing preventive medicine, patients with heart failure, it's not homogenous, but it's more homogenous than an individual surgical decision, I would think. But I don't think that's half of it. The right information is half of decision making. I think the other half is really helping patients clarify what's important to them. And this gets into what I think is the big trade-off with defibrillators. If you think this is a model from JAMA of patterns of functional decline. And there's 4 patterns. I just picked 2 here. But there's the one on the left, which is the chronic disease, where you have these up and down blips in function, and then you eventually die. Versus you're going along, and then you have sudden death. And defibrillators only treat sudden death. And like I said, if you ask patients, do you want to prevent sudden death? They say yes. You ask people, do you want to die in your sleep? They say yes. Well, all of a sudden, there's a discussion there. And this is where I got interested in this as a geriatrician, is older adults telling me they didn't want a lot of stuff done. Then they go off and visit with somebody. They're told, if I don't get this, I'm going to have sudden death. And they end up with something, and then I ask them about it, and they don't really know what they got, and they didn't really want it. That's at least what got me into it. I actually think there's a lot more nuance to that, but I'm trying to just simplify the point. I think the key point is that the bigger piece, I think, of shared decision-making is that sitting with patients and finding out what's important to them. And as I mentioned, I alluded to the fact that I'm having the crisis of AI being better than me at generating knowledge. We're entering a world where knowledge is not as powerful as it used to be. This values clarification, that discussion with the patient, that exploring what's right for them and making sure the treatments match what they need, that's not going to be easily replaced by a robot anytime soon. And that's a big part of our job. And I know you guys have those discussions all day long. And those are important and hard discussions, but I think that is an essence of what we do as physicians that's going to be harder to replace. But I think as we make these tools, we try and help people think through, well, here are the bigger trade-offs. What's important to you here? And with ICDs, we had a hard time when making this tool of even finding people who had declined. We knew of decliners, but often we'd talk to our cardiologists and they'd be like, oh yeah, there was that decliner. I can't remember his name, because they don't come back to clinic once they decline a procedure. So we couldn't find him. He's like, there was that wrestling coach who refused the defibrillator. What was his? We ended up finding like 6 or so for the interviews. But here's a quote from one who was a former hospital chaplain. So he was pretty well informed. He said, going into my decision is the fact that I can't work because of my condition. I can't work at the hospital. I can't work at the church. My life is sitting here watching TV. To take a defibrillator would just lengthen the process that I don't really want lengthened. I think he's pretty well informed to decline a therapy. I think a lot of times people decline things for the wrong reasons. Some of the other decliners we interviewed were said things like, oh, I don't think those data apply to me. I'm African American, and all of those studies were in white patients. Not wrong, but probably, he also had pretty significant heart failure and probably had a pretty good risk of sudden cardiac death. And he was like 50. And I'm not sure that's a good decision either. And so these are some of the kinds of things. I think that's a big part of our job that's not going to get replaced. So thinking about these trade-offs and these risks and benefits, we wondered, how do physicians think about the importance of their patients' sort of perceptions and things about this and their patients' understanding? So we did a national survey of the American College of Cardiology, got 1,200 respondents. And we asked them, to what extent do the following factors affect your recommendations regarding ICDs? And then we had them rank these things. And this is a survey technique for addressing social acceptability bias. If if we wanted to ask how important are patients' preferences, and we just ask it as one question, everybody's gonna say, oh, of course they're important. So when you have something where you think there's a social acceptability bias, you hide it in a list, and you're more likely to get an accurate response. Like if you were asking about heroin use, you would ask it within a list of other behaviors, and you're going to get a more accurate description of heroin use, for example. So we've used that social acceptability bias technique in the survey design to ask this. And you see, mortality data and guidelines were 3.8 out of 4. We just scored them 0 to 4 on a Likert scale. Patients' preferences for the device, 2.9 out of 4. Patients' knowledge about defibrillators, 2.2 out of 4. So I argue there is a right answer here. If you're doing shared decision making, there's patients' knowledge, the guidelines. We shouldn't be recommending things for which we don't know the evidence isn't good. That's our job. But then making sure they understand and making sure that what we're doing aligns with what's right for their life, that's the other part of our job. And at least in this survey, it was less important. This is a quote from one of my qualitative studies of interviewing cardiologists about how they talk to patients about defibrillators. And this is not a criticism. I feel this in my clinic sometimes. But this is the quote from one of the electrophysiologists talking about risks. I think my biggest concern is if I convey the risks to them too strongly, they will choose or make an unwise decision and not proceed with therapy. And I called this beneficence with paternalism, because paternalism is beneficence, essentially. You're trying to do what's right for that patient. This is how I feel when I protect my young kid from a bad story in the news. I don't want to expose them to the bad thing. But I'm not sure this is how I want you talking to me about my procedure, or how I want you talking to my father about his defibrillator decision. So it gets quickly into an ethical debate on some of these things. And we could debate this, because I think sometimes there probably are situations where we need to step in and do some of these things. And I imagine in surgical decisions, sometimes you have to really help people move towards the right decision. It's really, a lot of this gets very philosophical and ethical very quickly. But just to make that ethical case, patients don't like to question us. And there's quite a bit of literature on that. And this is from Seinfeld, obviously. This is Elaine. She goes to the doctor. The file's there. He has to step out. She picks up her file and reads it. At the top, it says difficult patient. So the doc comes back in and she confronts him and says, why does my chart say difficult patient? He looks at it, he's like, oh, that's a mistake. And he pretends to erase it. She's like, it was written in permanent ink. You just pen erased it. But this is a fear that people have. And there was a study in Health Affairs that highlighted this fear as well, about talking to patients about why they don't question their docs. So Health Affairs is a top-notch policy journal. I think it's run by the New England Journal group, or at least it's related somehow. But it's a very good policy journal. But this is a quote from one of the respondents in that study answering that question. Well, is the guy going to be pissed at me for not doing what he wanted? Will he do what I want, resent it, and therefore not quite be as good, or in some way detrimental to my quality of care? I think this is important. And I think if people feel this way, we don't want our patients feeling that way. I think we want our patients to be able to question us. We're certainly entering a world where patients are going to come in with a lot more information because they can gather it a lot more quickly. And so embracing that question and sitting there with them, there's a time concern. I do primary care. I'm perpetually behind when I have my half days of clinic. It's really hard to do some of that stuff. But I also don't want my patients feeling like they can't ask me questions or challenge me if something that I say doesn't feel right to them for their life. I think this gets into what is shared decision making. This gets to this slide. I stole this slide from an ICU doc in Peru. I was down at the International Society of Shared Decision Making, which was hosted in Lima that year. I think it was like 2013. The guy running the conference was Peruvian. He's at the Mayo Clinic. But one of his longtime mentors is an ICU doc there who does human rights work. And he put this slide up. And the guy running the conference was the guest editor for this. And he basically said, look at this slide. This is one of the worst things I've seen. This is terrible. This is not what patients want. This is not what doctors want. Look at this iconography. Think of the amount of suffering that happened in the last century with this iconography. A patient revolution is not what we should be talking about. We should be talking about a much more caring partnership with our patients. And I thought it was just a brilliant slide. And it was kind of a moment where he was challenging his longtime mentee and friend who was running the conference. So I like to use that slide because I don't think we want a revolution. I think we want a partnership with our patients. All right, so I'm going to segue a little bit into some of the more design work we've done. This is a domain of quality. This is another debate I get into, and a question a lot of people have: if I do more shared decision making, does that lead to better outcomes? And I'll tell you what, not always. When I show the LVAD work, our more informed patients were less likely to choose LVADs. Those patients probably not living as long. So if we measured clinical outcomes, it actually looks like the shared decision-making was worse. So I like to just highlight this, that there are different outcomes for different reasons. And effectiveness outcome is one outcome, and patient-centered outcome, according to the Institute of Medicine, or the National Academy of Medicine now, this is from their report, Crossing the Quality Chasm. These are different outcomes. Patient-centered outcome is, the way they define it, is just providing care that's respectful of and responsive to the patient's preferences, needs, and values, and ensuring that their values guide the decisions. I think that's really what we want when you do surgical decision-making or any kind of decision-making. Am I doing something that aligns with the patient's goals and values? So this is not shared decision-making, in my opinion. This is just putting a bunch of options in front of a patient and asking them what they prefer. I'll tell you though, when I was a resident, this is what it felt like when I was told by my senior resident to go walk in and have a DNR discussion with a patient, and I had no training on how to do that. I didn't really know how to do it, and went in, and it felt like I was just putting options in front of them that were almost impossible for them to even think about or understand, because it was this future thing of cardiac arrest. It's actually quite hard to think about. So this is not shared decision-making. There are formal definitions of shared decision-making, and I won't get into it, but you see the 3 bullets at the bottom: clear, accurate, unbiased medical evidence, clinician expertise in communication and tailoring that evidence, and then patients' values and goals informed preferences. Those 3 domains are really what a good shared decision is. Good information, a clinician helping tailor that evidence, and a patient whose goals and values are informing the discussion. If you get there, you're doing shared decision-making, whether you have a decision aid or tools or not. That's really the goal. My favorite definition of shared decision-making, however, is just a meeting between experts. I really like this because it acknowledges that we're experts in the clinical medicine, but they're experts in their life and what's important to them. And we bring those together, then we're sharing a decision. If you go too far one way, it's the consumerism model, like I showed in the last slide, of just putting a smorgasbord in front of people and letting them choose. I don't think that's good medicine. But if you go too far the other way, is the traditional model of paternalism, of just telling people what to do. I don't think that's right either. I think as decisions get bigger and harder, we should sit with patients and help them make those decisions. So a little bit about decision aids. This is what our shop has spent several years building and testing and implementing. There are international patient decision aid standards, and there's a whole bunch that goes into them, but basically a decision aid is something that provides information about options, tries to prevent probabilities if they exist, provide methods for clarifying values, and then any sort of structured guidance for deliberation or communication. There's a Cochrane review now of 205 trials of decision aids, And they're almost universally helpful in improving things like knowledge, patient-doctor communication, satisfaction, value treatment concordance, which I'll show you later with the LVAD, lowering decision conflict, lowering decision regret, and lowering the proportion of people who are undecided. So these things work pretty well. My criticism of those trials in that Cochrane review is most of them are done in pretty controlled settings. If you take patients and bring them into a lab and have a research assistant sit down with them and show them a tool or a video, and then ask them some of these questions, they perform better. That's actually not a big surprise to me, which is why most of the work I write these days are implementation science type grants. I sit on the implementation science study section at the NIH, because I think the challenge is not making a tool that can help people understand things. It's how do we get that tool to fit in the clinical workflow so that it doesn't create more time for folks. So back to the defibrillator, just a little bit of some of the things we've considered. Here's that SCUT-HEF trial again, and here it is again in a different way. This is an icon array, same data, 7 out of 100, 29 die. And you see we try to avoid framing effects. So we say with an ICD, 29 die, 71 live. Without an ICD, 36 die, 64 live. And there's a lot of data, mostly out of Michigan. If you show people for this way as an icon array, and then ask them that knowledge question like I showed you, if 100 people like you had their life saved or had an ICD, how many would have their life saved? They're more likely to answer questions like that correctly when they see data presented this way. And I actually think something you can take clinically, even if you don't have pictures or the data in front of you. I've stopped in clinic, I avoid using percentages when I talk about things. I really try to use natural frequency. So instead of saying 1%, I'll say 1 out of 100 people like you, or 5 out of 100 people like you. And I think using that kind of language, I use it with statins a lot. 5 out of 100 people will have some muscle aches from statins. And I think that's better than saying 5% of people will have muscle aches. And there's some data that 5 out of 100 more people will be able to understand and answer knowledge questions correctly if you present it that way. And so even from this work I do, most of the decisions I do don't have a decision aid. So that's something you can pull in and do that with. So ICDs, and this is shown up in a lot of society guidelines, it's now a class 1 indication to do shared decision-making for defibrillators. And actually Medicare mandated shared decision-making in 2018 for defibrillators, which was great. It also really killed my R01. We were doing a step wedge design and 2 of the sites had rolled out and 4 of the sites hadn't. And then they passed this mandate. So all of our control patients had to have the intervention. We actually had the Heart Rhythm Society's lobbyists help us make a case to Medicare to see if we could exclude the 6 sites from the trial for at least 2 years from this mandate so we could continue studying the tool, but they wouldn't let us. But when they told us that they wouldn't, they had a call with 6 people and said, yeah, we're really sorry. We're gonna think about future mandates and how we write them so that we don't undermine any research that's going on. So I thought that was cool, but it did really contaminate my R01. And then throw in the pandemic, and that was a really frustrating R01 to do implementation. And we still had some good results. I don't have the slides here. Very modest improvements in some of our outcomes, but for the most part, a largely negative trial. But it was just so dirty and contaminated with COVID and the mandate that it's hard to make conclusions. But interesting, there's push towards shared decision-making. There's concerns when Medicare mandates shared decision-making. Are they doing this just to control costs? And so there was a lot of pushback, and I think that's a fair concern because why else is a payer getting into this? But they've only done this a handful of times, and then I think they've slowed down. So yeah, there's a mandate, but like I said, implementing these things is really hard. There's lots of questions. So I make a decision aid. Who's going to deliver it? A provider or a staff member or somebody else? And if that's a staff member, will they be empowered to deliver it? How will it be delivered? Are we doing it electronically? Is it in person or mailed? And then different decisions require different depths of this deliberation. When I'm in primary care, I don't want a 30-minute video about should we do PSA testing. I want something that fits something quickly. But then the flip side, I'll show you with some of the LVAD data coming up. It's, you know, when somebody's in an ICU about to making a decision about one of the more major surgeries we do to people, 30 minutes watching videos, we heard from patients they wished it was longer. They want to hear from more patients. So different decisions require different depths of deliberation. And then when you deliver it, when you want to get, if you make educational material of any kind, you want to get it in a patient's hand right when they're thinking about that decision. But it's hard to know when that happens. With a defibrillator, I'm a primary care physician. I refer to a cardiologist. Cardiologist might refer to an EP. I know about defibrillators. I might refer directly to an EP. But still, somewhere in there is a decision window when that patient's in their head thinking about it. And that's when the tools we have would fit. That's what's nice about the LVAD. They're in an ICU. We kind of know when that decision window is, but in the outpatient setting, it's really hard. And I get into this delivery model. I want these tools not to take more time for a doc, because that's a killer. So if we can get things in front of people's hands before the discussion, they come into the visit a little more prepared, that's good. I was talking to an orthopedic surgeon around or an orthopedic video decision aid, and he's like, I don't like seeing patients if they haven't watched the video. It just pulls the discussion so much further down that I appreciate it. Same thing, Paul Verosi is an electrophysiologist at the VA that I work with, and he and his nurse mail these out to every patient as they're referred. Says, please watch this and read this before you come. And he's like, and then when they come, I can spend more time talking about what's right for them, and I spend less time just educating them on the basic material. And I actually think this is an exciting thing about ChatGPT is I might be able to make more tools quicker and then vet them so that people can have the information, and then really focus on encouraging the discussion of values, which I really think is the money shot. So that's a little bit on the defibrillators. Transitioning to our LVAD work. These are two people in our video. I like to put this slide up, especially when I talk to lay audiences about this or non-clinical audiences. This is Cliff and Don. We have video releases. They let us use their images in the videos. Almost identical on paper, mid-60s, advanced heart failure, a few comorbidities, but really their experience is heart failure. Cliff chose the LVAD, had it for 10 years, was actually in a commercial for UC Health with Jake Plummer, and is proud of himself that he's wearing his Bronco hat in our video. He was on our PCORI patient panel, just a great guy. And then Don didn't want a defibrillator. He lives up in the mountains. He actually wrote a letter to the clinic, guys, or not a defibrillator, an LVAD. Please stop offering me an LVAD. I know you want me to live longer. I hear you. I appreciate it. I can tell you care. I don't want one. I work for an insurance company, and there's a small insurance pool. And I know if I get one of these, everybody's rates go up. And I've lived a really good life, and I don't want to have a machine in me. And both of those, I think, were right decisions for both of these guys. And that, I think, is what a shared decision is. So just a little bit on the LVAD. I probably don't need to get into what is an LVAD for this audience as much, but just in case, it's basically a pump, plugs into the heart, sucks blood out of the heart, and sends it down the aorta to give you more cardiac output. That's essentially what it does. Vice President Cheney had one for a couple of years before he had his transplant. For a while, they were more common than transplants, although I heard, somebody could correct me in this audience, I heard from Larry that transplants are now more common, which they think is partially due to the fentanyl crisis because there's more available hearts, which is a little bit sobering to hear. But for a while, these were increasing pretty precipitously. So Larry Allen and I and Colleen McElvennon, who's a nurse practitioner in the heart failure group, worked and developed, we did a bunch of qualitative work, and then we developed this decision aid. We made 28 versions. We made a 30-minute video. We recorded a lot of people. Joe Cleveland, I don't know if he's here. He's actually in the video. Working with his agent was really difficult to get his video. I'm just kidding. So we did this video, and then we worked on studying this. We studied it in 6 sites, and we showed an improvement in knowledge. I mentioned good decision is an informed patient making a decision concordant with their values. So we tried to measure, did we improve the decision? Did we improve their knowledge? And we did. We had about a 5% increase in knowledge. Not a huge increase. In that Cochrane review, the average was about 13% increase in knowledge. But we had a huge increase in value concordance. And this is a hard thing to measure, but I've never seen it. I've seen a lot of people try to measure this. And it's about as easy as it gets in the LVAD. Because there's really a big value trade-off that rises above all the other values that they're competing with. And so we had people put an X on a line. Do you want, on one end, do you want to do everything you can to live longer, even if it means having a major surgery and being dependent on a machine? Or do you want to live with whatever time you have left without going through major surgery or being dependent on a machine? And then we had people put an X on the line. If they put an X on that end of the line and ended up with an LVAD, we called that value concordance. If they put an X down there and didn't get an LVAD, that was value concordance. So we scored them based on where they were on the line according to their treatment. And then this was the discordant. And we saw a huge increase, a 0.29 increase in a Kendall's tau, which is basically a correlation coefficient in value concordance. So we improved knowledge, improved value concordance in the 6-site study. And then secondarily, this is the rate of LVADs in the control group was 80%. In the intervention group, only 54% chose the LVAD. It's a huge 26% decrease in the number of patients going on to get an LVAD. I think that's partly due to our intervention. I think it's partly due, it was a step wedge design, so we were rolling out over time. And we did notice as the trial went on that all 6 sites were starting to use the tools a little bit earlier, not just use them in the ICU setting, but as they got experience with them, they started using them in the outpatient clinics as people were starting to think about this therapy. So I think the patients got a little healthier as the trial went on, which is when we rolled into the intervention group. So I think some of this effect could be that we were just enrolling people a little bit healthier in the trial, so they were not getting the LVAD because it may not have been appropriate yet. But anyway, we took this trial and that we had PCORI, that was funded by PCORI, and PCORI has a follow-up grant. PCORI is the Patient-Centered Outcomes Research Institute. It's a new funding agency that was established by the Affordable Care Act in 2011. And they fund a lot of patient-centered and comparative effectiveness research. So they had a call for people who had a prior result to do national dissemination. I don't think 7:33 is not the right time, is it? 7:48, okay, I'm almost done. This clock here is 15 minutes slow, so I'll just keep that in mind. So we decided to go big and implemented every LVAD program in the country. There's 180 of them. And so we wrote a follow-up grant to do basically a social networking marketing campaign, hired a communications firm to help us do this, figured out what some of the tailored messaging would be. And then over time, we contacted every LVAD site. And so you can see on the x-axis, I know it's a little small, that's time. It starts in November of 2018 and it moves along. And you see early on, when we first got the grant, there were 6 sites at the top. Those little 6 green bars at the top were the 6 sites from the prior trial. They'd already gotten the decision aid. Yellow sites were sites that agreed to work with us, wrote us a letter to help us get the grant. And then all the orange sites we had never touched. And then we did in May, we did a big national survey with 4 listservs, the social works, the nurses, the cardiology, American College of Cardiology. And we got a contact at each site. We asked them a bunch of questions, but our main question was, would you be willing to be contacted for future work? And then as we got a contact, then we started, if they said, yeah, I'm interested, we'd mail them a box of 50 decision aids and some users guides, and then give them links for how to access them freely online. And then over the course of the trial, we ended up getting a contact at every program. And you'll see the black bar at the top. There were 6 sites ultimately that refused the decision aid. And most of those reasons for those sites were things like staff turnover, or they were a brand new program just trying to get accreditation, or in one market where there's like 5 LVAD programs in a city, they were worried about the loss in procedures and the competitive advantage, because they have to do, I think, 10 LVADs a year to maintain accreditation, or maybe it's 4, I don't remember, but they wanted to do, they didn't want to lower their volume by using this. But that was only, we thought that was going to be a huge concern, and we only heard it from a couple places. So of those that adopted it, at the end survey, 123 of them said they were still currently using it. So 123 out of 180 LVAD programs in the country were using our tool. And of those, on the right, 80 of them were using it all the time as standard of care, 23 frequently, and then 18 of them had dabbled. So we're excited about this. We're actually finishing writing this up and sending it to Health Affairs as an example of a successful implementation of shared decision-making. And it's a fun case to think about. We're obviously excited about the results and how good they came out. But I think we got lucky that we chose the LVAD. It's a really unique place. The patients are largely captive in an ICU. There's already an LVAD coordinator who's already tasked with doing education. we did an interview of 20 coordinators, and they don't like the industry materials. They're like, they're pretty, but it kind of feels like I'm selling stuff. One of the industry videos, you turn it on and it basically says, there wasn't much thinking about it. It's either get an LVAD or die. That's like the first quote from a patient. And the coordinators didn't feel comfortable with some of these materials, so they were very happy to unplug those materials, plug in ours. So we already had a delivery pathway. We have an easy way of finding the patient. So you think they're sick in an ICU, and maybe it's not the best context, but it's certainly been one of the easiest contexts to implement anything that I've ever worked in, for those reasons. And the patients they're sitting there, they're often bored sitting in an ICU, so they're happy to have something that helps educate them about this major thing that they're considering. So we had a lot of good success here, and we're continuing with this. We're trying to expand out our suite of heart failure tools for things like inotropes and hospice and other big choices that these patients face. So a little bit of the compare and contrast with the LVAD and the ICD. I just kind of alluded to this. With the LVAD, it was really easy to figure out who would deliver it. With the ICD work, even with a Medicare mandate, I was working in outpatient settings. It was really hard to find someone who just even had time to do that. When was it going to be delivered with the LVAD? It was really easy because there was already a designated education section. With the ICD in the outpatient setting, we kind of had to invent that. One of the sites that did the best actually had nurses they called closers. And so every visit, it had a nurse at the end of the visit, and they're the ones who sat down with the patient and talked through it because they already had a pathway embedded. I think some of your clinics might have places like that where you've got sort of the team. My impression of surgeries, there's a lot of team-based decision-making, team-based care. So you actually may have some infrastructure set up for things like this if that's ever of interest. But yeah, some of the big, in the LVAD, clinicians saw a need for it. We interviewed the person who identified himself as the highest volume surgeon in the country. I don't know if that's true. That was his quote. But he said, I want to put in a lot of LVADs, but I never want to put one in somebody who doesn't know what they're getting into. And that's not what we heard from defibrillators. We heard a lot more, it's a low risk procedure. It just saves lives, prevents sudden death. We should just do it. This should be a quality measure. So we also had a good decision where there's just general universal agreement that the patient's perspective matters. So these requirements for shared decision-making, for a while, they were coming quickly. They've really slowed down, but they've done it for lung cancer screening. That was the first one. They did it for left atrial appendage closer devices, the Watchman device. That's one that you have to do a shared decision-making discussion for. Defibrillators, there's a proposal for carotid stenosis. And then in the LVAD coverage decision, they actually referenced Larry Allen's JAMA paper with the results of our trial as evidence, but they didn't actually put shared decision-making in there for LVADs. And I actually think of these 5, LVADs would be better than any of the others. So we actually wrote an editorial, a few of us, about if Medicare is going to mandate shared decision-making, let's make this a transparent process. Let's come up with what decisions we really think are worth mandating shared decision-making for and have some sort of societal community agreement on that, rather than doing it as one-offs where you get a backlash from the community that doesn't like how it was done. But anyway, I think that'll leave us a few minutes for questions, 7:55. Thank you for having me. I love talking about this stuff, if you can't tell, and I'm happy to entertain any questions.
Dan, Rich, Schulich, thank you so much for that talk. And I've struggled with this my whole career, and one of my mentors, actually John Cameron, and you'll recognize this quote that he used to say, you walk into a barber shop, you're going to get a haircut, right? And we're all biased. I'm biased. I think what I do, has a greater effect on patients than it probably actually does. And then you put on top of that, you want to please your division chief. How do you please your division chief or your chair? You do that by being busier. You do more operations. There's financial perverse incentives, right?
Yeah.
If somebody's on the fence, but if you operate financially, your institution, your division does better. So I worry about this all the time. And how do we build a better system to avoid this? So I have one answer, and I look forward to hearing yours. So, for new cancer patients, we've built this multidisciplinary model where any new patient is actually evaluated not only by a surgeon, but by a medical oncologist, radiation oncologist, social worker, and really an expert advanced practice faculty member who tells you like it is.
Yeah.
And I found that keeps me in check. Sometimes they just look at me and say, "Are you kidding? You shouldn't be operating on that patient." Or, I'll say to one of the medical oncologists, "Really, chemotherapy? That doesn't sound right." But I don't think this is the way most of medicine is delivered in the United States, and I really worry about this.
Yeah, no, I think the systems issues are vast, and yeah, you're right. I think you get out of the academic setting, and it's a lot more. You can do what you want as an individual doc, and that team-based approach, I think, is a great one. I think a lot of the work in shared decision making is implementing teams, and how do we get more of the team involved? That's certainly the way that Paul does it with the defibrillators at the VA with his nurse. Another one of those systems issues is the referral. We heard from electrophysiologists like, well, they referred to me. If I send them back without a defibrillator, I'm going to lose my referral path. There's another one, related to that. And I think those systems issues are vast. So that's why my case comes across as a little bit of science and a little bit of like pleading and preaching, because there's a little bit of a case to be made for we should do this. But that's just one piece of the puzzle. The systems issues are vast. Me in primary care, I do research in this. When I'm 30 minutes behind in clinic, boy, those shared decisions get a lot shorter. And I'll just own that and be honest, because it's hard. It's just really hard to fit it in.
Dan, thanks for your excellent presentation. In the vein, I have a lot of questions, but given the limitations of time, in the vein of this series of presentations being on local faculty who have extramural funding, how have you navigated the funding scene? You've been incredibly successful. Having reviewed your CV, I don't know how many millions of dollars you're the PI of right now. It's over 10, I believe. How have you tailored your research to the funding, the notifications of funding, or vice versa? How have you sought out funding to keep your research along your guiding light, but also achieve extramural funding?
Yeah, I think, I don't know, I could probably talk about that for a while, but three things come to mind. I think one of them is getting into the science, working with psychologists, and not just have it be a clinician who wants to do some improvement in patients, but really trying to advance the field and the science. So working with like Laura Scher as a clinical psychologist I work with, that helps with the funding. Things like PCORI and having a funding agency that really puts patient-centered work at the front is helpful. I actually love grant writing. It's a lot of fun. I know a lot of people don't say that, but I really enjoy it. And then that's not the only reason, but that's partly why I've migrated to implementation science. There are some implementation science funding calls. And I think just doing these things, making another decision aid to sit on a shelf is really not of interest to me. So I've kind of learned implementation science methods. I'm going to develop with stakeholder input. I'm going to try and make something that fits what the clinicians need and what the patients need, and then write that and use robust implementation science methods. Helps open up some other calls for this kind of work. I think that's a vexing question, as vice chair of health services research. There's a lot of people running around our department that are really struggling trying to figure that out right now, because the things they were interested in just aren't even fundable right now. And so finding those funding things is one of the keys. And if any of you have interest in anything related to this, I am happy to talk about your area, your interest. I love this stuff. I think you guys do a lot of this stuff, and you guys probably do heavier stuff than I do, largely in primary care. And so I'd be open to chat.
Thank you. Other questions? All right, Dan, thank you so much for joining us this morning.
Yeah.